Bem, chegamos ao momento final do nosso primeiro dia. Faremos agora a palestra de encerramento com o Dr. Thomas Coates. O título é The Title is Management of Iron Chelation Therapy. Portanto, eu gostaria de convidar ao palco para ser o nosso moderador pela primeira vez do dia, o Dr. Jorge Roberto Baldanzi, da MPAR Curitiba, Paraná, e mais uma vez, com muita satisfação, convidar o Dr. Thomas Coates, Children's Hospital, LA, USA. Por favor.
Well, I think there is no need for further presentation, so you can start soon. Please indulge us with a wonderful lecture.
All right, thank you again. And this is actually a little bit mixed from the last one. So what I'm not going to talk about is details of chelation, because I know that all of you have a lot of experience, with that. So we'll talk a little bit more about iron loading in a little bit more detail than I did before, about the goals of chelation, and again trying to sell this idea, which is totally opinion, that we should normalize iron levels in patients. Then we'll say a few words about trying to get the patients to actually take the medication, which I think is the biggest problem about doing any kind of chelation studies that you're trying to do, is you're never sure that they're taking the medication. So if we look at transferrin as the protein that carries iron, normally about 30% of it has iron bound to it in the plasma. And of course, it's the Fe+3 iron that it carries then to transferrin receptors on red cells to make blood. And also, this is a receptor-mediated process, so all cells in your body have transferrin receptors. But the number of receptors in particular tissues is determined by that particular tissue. There's a lot of variance from one tissue to the other. Red cells have the highest number, as you might expect, but actually in the bone marrow, red cell precursors have high levels. Actually, the later cells have high levels of transferrin receptors, and then as the red cells mature, they lose their transferrin receptors. So these things are really very tightly regulated by the body. So, when transferrin becomes saturated, the excess iron goes into the plasma, and it goes into the plasma in the form of so-called non-transferrin bound iron. And as we talked about earlier, when the transferrin saturation gets around 60%, the NTBI level goes way up. And LPI is this fraction of non-transferrin bound iron that is in the +2 state and is toxic. Again, as we mentioned earlier, red cells are transfused, and my red cells aren't showing up on here for some reason, but the red cells, supposed to be some here, get eaten by macrophages. The iron is the red cell hemoglobin is digested by hemoxygenase 1. And the Fe+2 either goes into ferritin, where it's stored and converted to non-toxic state, or it's excreted through ferroportin into the plasma. So again, as I mentioned earlier, every day about 25 milligrams of iron are recycled through this pathway, recycling of our own red cells, and this iron is then used to make new red blood cells. However, if you have ineffective erythropoiesis or the marrow gets shut off, then that excess iron also goes into the plasma, and you get marked elevation of NTBI and elevation of the toxic form of labile plasma iron. The cells in our body have other ion transporters, like the divalent metal transporter and the zinc transporter, ZIP14, and in the heart, L-type calcium channels. These are the channels that regulate calcium entering into the heart that are important for rhythm and contraction, etc., in the heart. None of these are designed to transport transport iron, but they do transport iron. And the expression of these channels on different organs is different. Likewise, each of these channels have two different molecular transcripts, one of which contains a iron-responsive element, so its expression is controlled by how much iron is there, and one that does not. So for example, the divalent metal transporter on the pancreas is totally non-responsive to iron. So if the LPI levels are high, the pancreas continues to load regardless of how high the intracellular iron concentration is. In the brain, the DMT1 transporter is highly sensitive to iron. And in the gut, the number of iron sensitive versus iron non-sensitive changes on the position where it is in the intestine. So this is how it regulates that iron absorption occurs in the duodenum, but not in your rectum. Thank God. Okay. So entry of iron into the pancreas, I look at that as sort of a measure of how long you've been exposed to this free iron. So what this means is that the loading and unloading of all of these different organs is different at different times, and it's impossible to know how that's going unless you directly make those measurements when you're treating them. So I already made this comment, the transporter and the zinc channels are how the iron gets in, but only the +2 iron, only the Fe+2. And the expression of these is different, and also the expression of ferroportin is different. So if ferroportin is the molecule that removes iron from the cell. So again, in the bone marrow, whether ferroportin is regulated by iron or not depends on where you are in the maturation of the red cell. So there's ferroportin that's regulated by iron, there's ferroportin whose expression is not, depending upon whether it has the iron responsive element or not, and that whole transcription regulation. So we have organ-specific rates of loading and unloading. So it takes, under full chelation concentrations of chelator, it takes 4 to 6 months to reduce the liver iron concentration by 50%. So you can drop the liver iron pretty fast. On the other hand, to drop cardiac iron takes 17 months is the T1/2. And pancreas and endocrine organs are somewhere in between, they're intermediate in their loading and unloading. So in my opinion, as I said before, the main target of chelation when I'm treating these patients is to get rid of that free iron, which is toxic and that is loading all of these other organs. The liver is actually pretty insensitive to iron, to be truthful. It can be really loaded and you can have fibrosis and you get the iron out and the fibrosis will heal. So it's not so bad. The endocrine organs, we don't really know, but they tend, once they get damaged, I think that's the end of them. So you've seen this picture before. This is an MRI of the heart. Here's the liver down here. You can, when the MRI is black, there's a lot of iron, and you can see that this patient has a ton of iron in his liver and also has some iron in the heart. When you tell a patient that they have iron in their heart, they start taking their chelator. And you can see here that the liver is now gray several months later. Liver iron is better, but there's actually more iron in the heart. So when people say there's no correlation between liver iron and cardiac iron, in part this is why. Because the levels change so quickly and because of these psychological factors and how fast you can unload the organs. This is iron loading in young children. Here we have, this is a normal level of liver iron right here. This is, notice, a logarithmic scale. And these are patients that have effective erythropoiesis, sickle cell disease, or patients with thalassemia in black, diamond blackfen, and CDA. These have ineffective erythropoiesis or decreased erythropoiesis. And it's pretty clear that the loading, that the red and the black dots are all in the same area. At 2 years, here we have patients with 10 milligrams per gram dry weight of liver. So you load very, very quickly. 3 years of age, 4 years of age, you already see cardiac iron in diamond blackfen patients. Here's the pancreas, and you can see very clearly, unlike the even distribution here, it appears normal pancreatic iron, R2 star. You can see that the patients that have active bone marrow are not loading their pancreas. And the patients that have ineffective erythropoiesis, the thalassemia patients, are loading their pancreas, and they're also loading their heart. So again, this is consistent with this idea that high LPI levels are loading through these channels and transporters into the heart and into the pancreas. So again, when I think of the goals of chelation, I want to first protect the cells from labile cellular iron and labile plasma iron, the +2. I want to prevent further accumulation of iron in those organs, and when you bind those LPI forms with chelator, you block their transport into organs. I want to reverse the organ damage and then, of course, establish negative iron balance and get the iron out of the organs. So this is a paper of Porter's from a long time ago, basically to make the point, if you look at NTBI in red, and these are blood levels of desferoxamine, you can see that as soon as the desferol levels go up, the NTBI level drops. And as long as the desferol is being infused, the NTBI is low. And as soon as you stop the desferol, the NTBI comes back up again. So the half-life of desferol is 30 minutes or 40 minutes. The same thing has been shown for deferocerox and for deferoprone, just that the shape of that curve is the inverse of the drug level in the blood. So all three chelators bind this toxic form of iron. So when I look at so this is my little summary of the chelators, and what matters to me is these half-lives. And you can use combinations of these medications, and I realize that if I was in the United States and the FDA, Federal Administration, were sitting in the back, which they can do, they would be walking me out of here in handcuffs because none of this is on the package insert. And we only do what's on the package insert. But this lets me combine these things to try to get chelator all the time in the patients. And I think you're aware of the toxicity of these medications, and Fernando talked about the agranulocytosis. And again, I don't know what I could, I was really happy to hear his talk this morning. I don't know whether I can divulge this or not, but at the FDA meeting where this stuff was approved, you remember Susan Sherman? So one of the people, they couldn't find anybody to be on the panel on the FDA. They actually asked me to, but I had to recuse myself because of some comments I had made in public. But the head of blood diseases, when she heard about having to follow blood counts weekly, she said, "This is crazy. Why are we doing this?" I don't know if that made it to the record or not, but anyway. So the big problem with this drug is it has to be given constantly because it's a short half-life, and it has some other side effects you're aware of. Deferoprone is very effective, as you know. As we heard earlier, it's the best drug for cardiac function, and it's the best drug for getting into protecting mitochondrial function. And its half-life, I would like to have it be longer, but you have to give it 3 times a day. And it's very well tolerated. We have 120 patients on transfusion. About half of them have sickle cell disease. Most of them have been converted over to deferoprone because they don't take the deferocerox because of the GI toxicity, and it's well tolerated, but not on the package insert. Deferocerox has a long half-life. They've recently introduced this oral form. If you haven't used it, this is a pill rather than a dispersible tablet. This is very well tolerated, so patients seem to be doing pretty well on this version. As with all of these chelators, there's a dose response. This is iron excretion based upon drug dose, and the more drug that you give, the more you excrete. But you have to be aware, if this is the number of how much transfusions are getting. So if you have more iron coming in, then it will require more chelator to get rid of it. Now, people talk, this is just the way I do this, but whether it's right or not wrong, you can decide. But I don't try to adjust chelator dose based upon ferritins or iron levels. I think you're crazy to do this you don't really know how much they're taking, whether they're compliant with the medication or not, and the relationships between the excretion and the dose that you prescribe, which is not the dose that they take, is so variable. So I adjust the dose based on toxicity. I give them the highest dose that's safe based upon their iron level and based upon their renal function and the toxicity that they have. And then as their iron levels come down, I back off on the dose. If your iron level is 3 or 2, you really shouldn't be giving full dose of chelation to everybody. Just another quick point in this equation that you've seen before, environmental factors are important. We looked at these vitamin levels, or this, what we call the veggie panel, vegetable panel. One of my nurses started making fun of me when I was ordering all this stuff, and it's now become the veggie panel in Los Angeles. 37% of iron overloaded patients have undetectable thiamine. Okay? And beriberi, of course, it's the same word in Portuguese, causes heart failure and also CNS problems. We haven't seen any CNS problems. Vitamin C, people say don't give vitamin C if you're iron overloaded, but we have patients that have rickets, they have a vitamin C deficiency, they need some vitamin C. Selenium, 75% low selenium. Selenium is important for all of the antioxidant enzymes that you have. 16% very low ceruloplasmin. You need ceruloplasmin to convert Fe2 to Fe3 so you can remove it from the cell. So if you have low ceruloplasmin, you have a bone marrow picture indistinguishable from myelodysplastic syndrome. You get bone marrow failure and elevated ferritin and ring sideroblasts in the marrow. So we don't like to treat little kids because we're concerned that chelators are going to affect their development, but there is zero data to my knowledge on this. I mean, on chelators causing problems. There is data on the relationship between iron deficiency and cognitive problems in children. We don't start unless they have a high ferritin. We get LIC measurement in all of our patients, and we usually let it get up a little bit just for safety's sake. The most important thing here is we think that we ought to have some chelator present all the time, and we try to achieve that with different combinations of chelators. And monitoring, you know all about that. This helps me when I'm thinking about treating patients. The total body iron is linearly related to how much iron is in your liver. So if you measure the liver iron, you get a good idea of the total body iron. But of course, this doesn't tell you anything about how much is going in the heart versus the endocrine organs. But the liver has got the biggest mass, it has the most iron, but anyway. We measure that now using MRI. Again, you know about this. This is Tim St. Pierre's data using his methodology, which he's using the same physics as what John Wood and I published. Actually, he beat us by a couple of months in blood. Correlation coefficient, 0.96. So there's a very good relationship here. And this is, the red line is St. Pierre's regression line on our data. So we get the same thing by these two techniques. Also, by the way, the measurement error is only 5 to 8%. The measurement error with liver biopsy is 17%. A word about ferritin. This is that we found the same thing that Brittenham found 100 years ago. If you follow the 2,500 ferritin along, this is a population of thalassemia and sickle cell patients, liver iron concentration, ferritin. You see, if you follow the 2,500 line across, here's somebody that has a 2,500 ferritin and a liver iron of about 4. And here's a patient that has a 2,500 ferritin and a liver iron of 35. So the correlation here is 0.8, highly significant. If you square R squared, it's 0.64. That means only 64% of the variance is explained by the regression. The variability is huge. We thought for a long time that if you followed the trend of ferritin, that was okay. We knew that the absolute numbers were not so great, but that the trend would be good. So we actually did that experiment. It was triggered by a patient, a single patient with thalassemia. This is her graph. First of all, the blue is the ferritin. You see how much it goes up and down. measure the ferritin every time we transfuse them, so every 3 weeks. The red is the LIC, liver iron concentration. And she gets to be about 19 years old, and that's when they begin to start to comply. We say in English they get religion. Okay? And her liver iron and ferritin come down very nicely. And then around here, when she's, you know, I don't know, 24, 25-year-old college student, you see her ferritin starts to go back up, and it gets up to almost 2,000. At the same time, her liver iron is dropping. And what I worry about this is, you know, she's actually, I wouldn't have thought about that. Are you an internist? Yeah, okay, so I'm a pediatrician. My kids don't drink. You know, they don't do sex, they don't do those things either. They're children, for God's sake. She's a very responsible young lady, and what I worry about this is that her doctor may say, I think you're lying. I don't think you're taking your chelator. And I think that support and these kinds of things are critical for people with chronic diseases. That's my biggest worry about this. So anyways, we looked at these and did a fancy analysis, and we considered correlating to mean you were within 200% correlation between change in ferritin and change in liver iron. So we accepted 200% error. And that was okay 38% of the time. 26% of the time, the ferritin was going up and the liver iron was going down. So we think that this is still a useful test, but making critical decisions, especially with your very low levels about how to chelate, you need to, I think it's concerning. So based upon largely the data, the stuff that I talked about in my last talk, and this expectation that they're going to survive, we really try to normalize the liver iron in our patients, if we can do it safely. We are shooting for liver iron levels that are less than 2, and probably 30% or 20 to 30% of our 120 patients are like that. And we actually have seen no serious. We've had a couple of GI bleeds. We've had one case of severe nephrotoxicity with Fanconi's syndrome, but really doing pretty well. Monitoring, you all know about this. I think this is the one point I would say, be careful about making critical decisions based on ferritin alone. Dr. Piga talked about this. Cardiac dysfunction due to iron overload is a true emergency. I mean, real emergency. Admit them to the hospital right now. And I would also echo the point that he made about the steroids. There's significant adrenal insufficiency that's underlooked. And so we just give them a blast, a big dose of steroids when they come with sepsis. You can't hurt them by giving them too much. They can die if they have adrenal insufficiency and you don't do it. So we treat them and think about it later, in that case at least. Monitor organ dysfunction. Don't forget the adrenal gland. And again, as Dr. Piga said, the test may be okay, but you need to, if you really want to prove it, you need to do ACTH stimulation testing. So why does chelation fail? The biggest problem that the drug companies have is they can't design a drug that works if you do not take it. And I'm sorry, Fernando, but your drug has not made any progress in this area. Yeah. Yeah, okay. So, I love this quotation from Voltaire. He realized this in 1764. The perfect is the enemy of the good. I hear so many times that physicians get all tied up in trying to perfectly follow these protocols and follow what the package insert says. And I think that this is a mistake. I'm all in favor of randomized prospective studies, and Dr. Piga and I have battled this out over wine in the past. I think we are both on the same wavelength. But I think that we have 3 chelators and we should use them and interact with the patient and try to figure out what combination with the patients is going to enable them to take these medications in the face of everything that they have to do every day. And the main principle here is we want chelator all the time to block the MPI. We should resist allowing perfect adherence to drive what we do. We should definitely watch for toxicity very carefully and figure out how to do this, because I am worried about how combination therapies are going to work. But Fernando's seen this before. We need to continue to seek the truth, but we need to stay away, as far away as possible from people that think that they've found the truth. Thank you.
Thank you, Dr. Coates. So we have time for questions. And Fernando would like to start it.
Tom, one of the slides that you showed was John Wood's publication on the iron removal from the heart and liver, showing that the patient became adherent to chelation once he realized there was iron in the heart. And then, as a follow-up, there was less iron in the liver, but the iron, I don't know if it was increased or have no change. So, and the question is that you remove iron from the liver first and then from the heart. I think that's right, but not for all three chelators. There's a difference in there.
Well, I don't think that the order, in that picture, I was simply trying to make the point that the iron concentrations are different in the liver and the heart. I'm not trying to imply. I think when you have chelator present, you stop loading the heart and you stop loading the other organs. And if you have chelator there all the time, the liver is going to unload probably faster because we know the half-life of unloading. But I wasn't trying to imply any cause and effect there with that picture.
Okay. Oh, it was just one thing that's because I think there's always this view that is the iron removal is from the liver first and then from endocrine or heart later. I don't think that's correct.
I agree with you. But I do think, and we'll see what you think about this, that if you have a lot of iron in the liver and somebody doesn't take their chelator for 3 or 4 days and their LPI levels are astronomical, they're going to start reloading their heart again really quickly. So I think there probably is some connection, but that's, in my mind, that's probably what it is. It's not related to the rate of loading or the rate of unloading. The liver can load through transferrin receptor 1, transferrin receptor 2, also through developmental transporters, through all those mechanisms. So it has lots of ways to load. So it loads pretty quickly and it unloads pretty quickly. But I don't think that there's any connection that way. Yeah.
Now the second point, just to address about this chelation. You, I think you have defined very well that the best chelator is the chelator the patient can tolerate, right? No matter what it is. If they can take it, this is the best chelator for them, no matter what. But one thing that I think I want to address about what you mentioned about the ferritin, because taking 3 times a day is not easy. Taking 3 times a day. But I think there are data now from epidemiological studies, and Maggio has shown this in Italy. For some reason, even if you do not comply very much with the ferritin, there's an improvement in iron toxicity, not exactly iron overload, but iron toxicity. Improvement heart function, and also improvement survival, even if you're not very adherent with the ferritin. So there's some reason there that is chelating this free iron somewhere.
So I agree with you 1,000%. Okay. And again, in the United States, you know, we don't have nearly the experience that the Greeks and the Italians do and people in the other part of the world. So I have to say that to start with. I'm a little bit embarrassed. I don't want to sound like I know it all, but so we have a number of these single patients that have been instructive. And when I said you should not adhere to what the package insert says, that means you take your XJ daily and you take your XJ once a day, or your deferriprone once a day. I mean, that's a modification that we would think about. Now, I'm not going to say, I'm not telling you that we push this primarily. We try to have chelator circulating all the time. But if that's what I need to do, and our first patient that we ever treated with your help is a patient with thalassemia major who had anaphylaxis from desferal, was in the intensive care unit 3 times on pressors, still has a cardiac T2 star of 4 to 5, 10 or 15 years later, and takes his deferoprone once a week if we're lucky, 2 or 3 times a week if we're really lucky, and his ejection fraction has been greater than 70% for that entire time. So that's why when I say, you know, people want to be religious about following all this pharmacology, we try with him to have a background of XJ, so he has some chelator there all the time, and we try to get him to take the deferoprone as often as possible, and we tell him again and again that deferoprone is the most important drug for him. That's the kind of negotiation that I'm talking about in this approach that Voltaire suggested.
If George allows me to make one more question, otherwise I'll ask someone else.
Well, it did not depend only on me. I have nothing to do.
Okay, then let me ask one more question, because you're suggesting that chelation therapy starts at 2 years of age. But I
arbitrarily.
Well, the thing is, I would agree with you that this should be appropriate 2 or even 3 years of age for desferal.
Yes,
for
we'll
the
agree.
oral chelators, because there's lower affinity for iron, most likely there's much lower risk of toxicity. And I'll tell you the experience. We're doing this study in patients with PCAN, panthenol kinase. So they do not have iron overload. They have just iron accumulation in specific areas of the brain. And sometimes they start the ferritin at much lower dose that we're treating, usually about 30 milligrams per kilo. And they start with the ferritin of 10. They start with the ferritin of 10. And they maintain the ferritin of 10. Sometimes we see a decrease in the hemoglobins, slightly decrease in hemoglobin or MCV. And what we do, we supplement those patients with iron. And no toxicity. So it's most likely in a patient with thalassemia, if you give an iron chelator with lower affinity for iron than deferoxamine, and both oral chelators have lower affinity, you most likely not find too much toxicity. There might be some things on the kidney or others that may be related, or the gut. But I would propose that we need to avoid the iron load in children.
No, I agree with you completely, and especially, you know, for those kinds of reasons. And I mean, I don't know how many people are doing MRIs at age 2, but you saw, I mean, there are 2-year-olds with liver irons of 10. So, I mean, they load very, well, that Angelucci paper tells you, you can calculate what the liver iron is based upon how many units of blood you give somebody. So, I mean, I agree with you completely. And this fear of before 2, it's left over, and you know, yeah, absolutely something we should discuss. And then based upon what they're talking about with fertility, and the fact that we know deferoprone is an effective mitochondrial iron protectant, maybe we should think about 30 milligrams per kilogram starting at 6 months until they get to an older age, and then go up and follow developmental. I don't know. There's a lot to be known. I agree completely with you, Fernando.
Along the same line, if you're talking about ferritin, and I totally agree when you say that iron in ferritin is ferric, so it's not exactly the one that's causing the problem. It only means that you had iron +2 before. And we know ferritin trends do not serve any purpose to change your chelation therapy. What should we do about using ferritin levels? Like, what's it useful for?
Stop.
Before, we used to use ferritin levels to determine therapeutic index, because we were afraid that deferoxamine would be toxic in patients that had low ferritin. But now, what should we do with that?
Well, I mean, again, this came up a little bit earlier. I mean, we have patients with ferritins of, 200, even 100, even lower than that have high liver irons, and we keep chelating them. we use it, I mean, it's cheap and it's fast and it's easy. So the way that we use it in our clinic, and we get ferritins every 3 weeks, is if the patient, if we think that they are taking the medication and the change in the ferritin is consistent with somebody who is being compliant, is taking the medication, then if the ferritin is steadily coming down, we may check an MRI in 15 months or 18 months instead of checking it at 12 months. If the ferritin, and I get calls about this all the time, they started somebody on chelator and they're 3 or 4 months or 5 months out and the ferritin hasn't changed. My response is, so what? I mean, it can take longer than that. So if we think somebody is taking their chelation and the ferritin just doesn't make sense, we jump in and get an MRI. So that's how it helps us. I don't think that it's useless. And in many places, it's all you have until we find something better. So I think we all know that IL-6 and inflammation markedly increase ferritin production. Iron also, Fe2 inside the cell, triggers transcription of ferritin. The ferritin is entirely intracellular, except what leaks out. So if you have damage to cells, it's released, just like LDH is when you get liver damage. So we've seen ferritin go from 2,000 to 50,000 in 48 hours in people that get liver infections. So you just have to look at all of those factors when you interpret the results, and you certainly shouldn't try to bring a liver iron down to 1.5 by using ferritin. You really need to have this other measurement to do that kind of fine-tuning, in my opinion. And for the patients with localized iron in, the Friedreich's ataxia and the pantothenic kinase deficiency patients, I mean, you're on your own. You've got to, I don't know what you do. You follow their symptoms, I guess. Okay.
Any more questions? So I think we can close this section. Thank you, Dr. Coates.
Thank you. Thank you once again to Dr. Coates for being here with us and give us 3 very excellent lectures. Thank you very much. So, now I'm going to speak in Portuguese. Muito obrigada a todos vocês pela presença ao longo desse dia de palestras. Em nome da Associação Brasileira de Talassemia, Brasta, agradeço imensamente a presença de todos vocês. Obrigada.